Good afternoon, everyone. Thank you for coming to the fourth session of the afternoon, and thanks so many of you for coming to this session. And as Patricia's been encouraging you, please come towards the center. We want to have a good dialogue. We want everybody to participate to the extent that they have great ideas to share. So the closer we can get, the easier to be to hear each other and share our good ideas. I know it's late in the afternoon, but we have a lot of things to do before we adjourn to the reception. So let that be your motivation to work hard so we can get to that. We are going to do several things with you this afternoon. Let me start by introducing myself. Sorry, it's been a long day. I'm Kathy Gross, and I'm one of the co-facilitators. I just feel like you all know me because I've been here all afternoon. And let me.
I'm Lucy McGowan. I've been here all afternoon.
And poor John Norsini has had the misfortune of having to sit up here with this afternoon, but he's had some wonderful comments, so we've continued to take advantage of his expertise as a contributor to the forum discussions. All right, so we're going to do several things this afternoon. First, what Lucy and I would like to do is we're going to do kind of a brief highlight of the discussions that have been held at the previous three breakout groups related to this topic here, which is assessing the interprofessional learner from education to workplace. Then we have a proposed challenge related to this topic that we're going to throw out to you. We're going to have a brief discussion of how we might refine that challenge and make sure that we have general consensus on that be the challenge that we're going to work on. From there, we're going to talk about opportunities at the policy, institutional, and individual level. And hopefully we'll have energy for our last task, which is to come up with a strategy for how we might start to address this challenge. So it is ambitious, but that's why it's great we have a bunch of you here to contribute to the conversation. So mindful of time, I'm going to start by giving you just a brief summary of what was discussed the very first group, which was talking about challenges at the policy level, and then I'll turn it over to Lucy to talk about the institutional level. We actually had no problem coming up with lots of challenges at the policy level, but to highlight some of the big things that came up in that group was one, at a policy level, what are some of the issues that could be tackled to enhance both opportunities for interprofessional education placements, to enhance the quality of field placement supervisors. So that was a big item that got a lot of traction. We also talked about different entities that might, at a policy level, have opportunity to influence both the occurrence of interprofessional education, but also have a role in promoting high-quality assessment of the interprofessional learner. And for that, we identified that certainly our various accreditation units, those responsible for accreditation of education and training programs, might be a good target. But we also talked more broadly about systems that accredit healthcare systems, and looking at that as another leverage point to try to foster both interprofessional education and assessment of the interprofessional learner. We also talked a little bit about how interprofessional education might be more clearly tied to the triple aim, and getting that piece in there, making how we might operationalize that at a policy level.
Yeah, so then we moved on to the institutional level, to the meso level. And the challenge that was generated as a result of our discussion was folks wanted to discuss further the lack of an ability to perform high-quality assessments of students' interprofessional learning in a practice environment in an educational setting, but in a practice environment before students graduate and go out into the workplace. So in addition to that, we also talked about the need for a shift in values among all stakeholders within an institution, faculty, administration, students, to appreciate the importance of assessment, to appreciate the importance of interprofessional education, and the marriage of the two, which is really the subject of this session. We talked a lot about the need for faculty development as part of that, to develop skilled faculty members who are trained and have a toolbox to be good mentors and to perform robust, valid assessments of students in the practice setting.
I'm looking at my notes now from the conversation at the individual level, and it's very
It-
similar
it
to what
was,
Lucy
yeah.
just said. And trust me, they're different notes. A lot of what we did talk about as well was about the culture within the institution, and particularly looking at the faculty and what's their commitment to interprofessional education, what's their commitment to high-quality assessment of the interprofessional learner, and how we might build those capacities. The other thing that we talked about is the opportunities that longitudinal assessment might provide of the learner, looking at their progress over time, and it also could provide some helpful feedback at the institutional level to convey the outcomes of their training programs.
I think the only other thing I wanted to mention is another topic that I think actually came up in all three settings, all three levels, was a need for further development of joint ventures and partners with the healthcare system in order to provide placement opportunities for students to be assessed in a interprofessional capacity.
So with that, why don't we move along and we'll present to you the beginnings of the challenge that this group might take on. And we'd like you to just take a moment, look at this, and then we'll see how we can refine the language in here and then move on to our opportunities. So what we have now, based on the discussion from the three groups prior to this, is the challenge is assessment of interprofessional competence along the continuum from training to practice. Take that in, and then we'd welcome some ideas about if it's a challenge that feels good for this group and how we might refine that a little bit.
And we'll offer up two greater levels of granularity that we deliberately left out, and we'll hope that you all can comment on. We didn't narrow this to either the individual or the team level. We can probably only tackle one in this session. So if we are going to start with a challenge, something like this, and refine it, think about whether you would like to focus the time on the individual, assessment of the individual, or assessment of a team. And the other issue is, should we tie this to the triple aim? Should we explicitly tie this challenge to that, or not? Does it make it too cumbersome? And don't everybody talk at once. But do turn on your microphones.
I would suggest that we absolutely should tie health professional education to the triple aim. So whatever it is that we end up doing here, I think that we should keep that in mind.
Okay, absolutely.
Yes.
Okay.
I was going to say that exact same thing.
All right, we have a
All
second.
right.
We have a second.
I mean, I think the only question should be is why wouldn't we? I mean, just give us some reasons why we wouldn't do that.
So I'm not going to argue for why we shouldn't, but I think it would be helpful to be clear that that's the ultimate aim and outcome, but that we wouldn't be tying in a linear way the assessment of interprofessional competence as equaling an impact on the triple aim. So I think that clarification would be helpful.
And just to add on to that, I agree absolutely with this, but one of the big challenges with interprofessional education in the clinical setting has to do with the lower cost piece of this. And so it has to be the lower cost writ large, not the lower cost within the individual institutions that might be providing interprofessional education. Because I think one of the reasons one of the obstacles to gaining a greater foothold is that institutions who are trying to convert to a team-based practice environment, interprofessional practice environment, the last thing some of them think they need is a bunch of students running around trying to do education within that context. So I'm a little wary, not wary at all by having that in there, but we just need to understand it's for in the overall piece, not expecting any cost savings to happen right away if you had interprofessional education into the system.
Well, if I could offer a suggestion to that, that sounds like something that'll fall into the strategy piece of this, and as we move forward with fleshing that out tomorrow. So if you're comfortable with this as an overall challenge, I think we'll make notes that needs to be articulated.
And I'm comfortable with this, but I am a little bit disquieted with the strategy that we've taken so far, which is we've gone from curriculum to assessment of curriculum rather than starting with practice and exemplars in practice and then figuring out which curriculum works for that. You can go either way, but we were having emerging models where people are making good progress around the triple aim, and that's a functional test for whether what aspects of IPE we ought to be looking at. And it's different than we've done all along, but we've got to keep these two issues in equipoise, both the educational piece but the practice piece.
Could we try to plant a seed here? Do you think you could fold that into something that we could craft into our opportunities language?
Yeah, and I think, I think we can.
Could work there.
Yes, Evelyn.
I worry sometimes that we isolate interprofessional competence and create another silo, an interprofessional silo sometimes. And so I wonder if the opportunity here along this continuum is to look for those opportunities in complex patient populations where interprofessional competence becomes one of several other buckets of competence and therefore becomes more integrated and seamless to the learners, whether they're practitioners or students.
I also think that may make a very good opportunity that we'll want to call out a little bit further. If that would be amenable.
I think one of the, this is being devil's advocate because I don't believe this, but one of the challenges that people always argue is that health professional competence is probably has a pretty narrow band of impact on the triple aim, on outcomes of various kinds. And so we're really talking about just a relatively small amount of the variation is explained by how competent the professionals are, whether as a team or as individuals. And so one thing is to claim that and define it, say there are only certain of these outcomes that we even hope to impact, and define those things, and not have a general statement that we should be improving the quality of care and raise the expectation that it's going to be more dramatic. I think people don't want to do it because they're afraid that we're going to demonstrate that we don't have any impact, or we have very little impact. And I think that's something we have to manage as a public relations issue.
The suggestion that was made earlier in terms of not making the statement too linear help with that?
Yes. So, I mean, my challenge to actually do this work is to create a chain of evidence, not a single jump. IPE, better patient outcomes, but IPE, better competence, better outcomes, and then try to put those arguments together as theory, not a single project.
We are going to need to move on, but we haven't resolved the issue of are we talking about individuals or teams? Is there a sense of what you want us to focus on?
I think if we assess the individual, then we know that the individual is interacting in, complex health systems, complex educational systems. To assess or evaluate or measure a team outcome becomes far more complex. It's kind of the difference between individual and family therapy.
Other thoughts? General consensus on that?
Individuals more manageable.
If
The only thing I can think of, again, kind of earlier what I said, is you could think about assessing teamwork or team skills at an individual level. So do individuals have the right skills that allows them to participate in a lot of different teams? I think that's probably the focus at this level.
Yeah.
I just think if you take it to the individual level, you could also have another challenge, though. If you're going to link it to the triple aim, how do you display that the individual had an impact on cost, quality, if they're a member of a team? So that would be the challenge if you took it to the individual level. I mean, the triple aim outcomes are much easier measured by the impact of the team. I'm not sure how you would do that.
The concern that was just raised, yeah.
depends on how attenuated you accept that the triple aim goals are.
Seems to me that we can think about a stepwise approach. And I think we have enough challenges figuring out how to do it at the individual level first. If we can figure that part out, then I think we can have a much better sense of what it really means to be part of a team. And the idea of assessing team skills of a team almost in and of itself is a catch-22. So I would suggest we start with sort of a continuum. And whenever you're trying to lead a change in culture, you start with the low-hanging fruit. And this isn't even all that low-hanging at the individual level, but at least it's one step easier than the whole team.
Sounds like most folks are in favor of focus on the individual, but we've had several people speak to some concerns about the language in here relating it to the triple aim. Do we want to take that out, change that?
I don't think it's inconsistent. If we're talking about assessing individuals for their ability to be a good team player, and team is then connected to, collaborative team practice is connected to triple aim, they're connected. I don't think that's a concern.
I would just like to raise the issue about team again, because we're not training everybody for teams that don't often exist. I have a problem with, everything's a team. It's just too easy to sort of fall into that. And if you're trying to measure it, trying to measure teamwork when you're working with a quite a loosely collaborative group is quite tricky. So I would encourage us to think a little bit more broadly.
So exercise team.
I'm totally with Scott on that, and I think using the word collaborative practice gets us away from looking at the formally constituted team, because we have all sorts of people who work together and not in formally constituted teams. And I think we're not just looking at team function and the eventual impact on issues such as the triple aim, but we're looking at a broader set of even health human resource indicators that we don't yet know how closely they are linked to collaborative practice models, so recruitment, retention, and how that makes a difference to patient care, patient outcomes, et cetera.
Yeah. Ready to move on. Okay. We now have to populate 3 slides. Each one, we don't have to put a lot, just a couple really pithy, great ideas. Based on this challenge that we've now articulated, what are some opportunities at a macro level?
I'll stop talking soon. In Canada, we have done some work on accreditation of education programs, on accreditation of interprofessional education in 6 disciplines. And I think that is making a difference, because it is, whether you like it or not, it is kind of the stick rather than the carrot in making change.
Thank you. Yeah, that came up in several of the discussion groups, so there seems to be some resonance to that idea.
Healthcare reform will provide policy incentives potentially if we make those links.
Okay.
I like the accreditation comment. Having just completed our accreditation report, we like to think we do it because it is the right thing and will improve quality and safety. But when you're required to do it for accreditation, you're more likely to make it happen. And in addition to the accreditation agencies, I do think you need to still work with the policy at the legislative level for higher education. Once legislation passes, laws that we have to have interprofessional education and that there's incentives for that at the higher education level, I think it could make an impact. Higher education right now is kind of struggling. They're kind of the wicked witches of the MOOCs and other tuition-based issues. So I think having legislative policies that give educational institutions medical schools and all universities some more incentives at the legislative level will, again, improve the quality of the interprofessional education.
The other one that I just thought of when you were talking was the Canadian Academy of Health Sciences is just completing a panel report on scope of practice. And one of the primary aims of that was to look at whether scope of practice is either a barrier or a facilitator to collaborative practice models. So I think at the policy level, scope of practice is probably important to look at as well.
Nice work, you guys.
Yeah.
Motivated to get to your reception.
And as we move on, if we need to come back and add anything to the previous ones, we can always do that as well. So on an institutional level.
Credentialing, HR rules, and EHR development.
It's late in the day.
I think at the meso level, this is where I would include engagement of patients and families in the assessment process.
I think there's opportunities to incentivize at the institutional level when we think about guidelines and criteria for promotion. One of the big things for any faculty member who's on a tenure track is, particularly in the first 6 years, they're going to be focused on doing things that are going to help them to get tenured and promoted. And if participation in interprofessional education is not part of that, then they have a disincentive. And I think we're starting to see this at a national level in several areas. We're starting to talk about embedding what we really care about in the promotion processes.
I just wanted to add that we've heard a few times today that faculty development is also a big part of what is needed in this area.
Yeah. I was just thinking about it and wondering, could it go here and on the individual level as well? I don't know.
Comparative effectiveness trials across institutions of various educational and other assessments. And a part of that is also sharing resources across institutions.
Along that same line, I would say sharing data across institutions.
Before we move on to the next,
one
okay.
more.
Yeah.
Along the lines of accreditation, so it probably belongs on the other slide, but how that drives academe, it drives hospitals through the Joint Commission. The Joint Commission says, we expect this, you betcha, it's going to happen. So, that's probably more on the policy side, but it makes the wheels turn.
I wanted to go back to the concern that you had raised earlier about, and I'm not articulating it well, but borrowing from what we know is working in practice and how do we drive that process back into the educational assessment process.
Identifying best practices and retro engineering IPE interventions.
Anything else, or should we move on to the individual level?
So on behalf of the nursing community, I would encourage us to think about building regional collaboratives because a number of nursing programs sit in isolation of other health professions programs because of the vast number of programs there are. So it's really difficult for them to engage in interprofessional work when in fact they may be the only profession. And there may be other disciplines who find themselves in that boat as well.
That's a great suggestion.
I think it'd be great if we could come up with sort of an incentive system for hospitals to create interprofessional collaboration. I don't know, I feel like it'd be interesting to have like an accreditation for hospitals that do it well, and then that would encourage other hospitals to try to work on creating forums for that to happen actually in practice. Yeah, in the last session, I gave an example of magnet status that they do it for nursing, and there could be something like that for interprofessional collaboration.
Use, there are some really good examples of interprofessional collaboration in community settings and in nurse-run clinics, but in general community settings. I think use some of these best practices as models for how we can translate that to other organizations, so that we wouldn't feel that we are constantly discovering a new wheel. There are really using across settings would be, use of best practice across settings would be a very useful thing.
Maybe that would, yeah, maybe on for the institutional level.
Perhaps we shouldn't limit our examination of best practices to this country, and we should look at best practices from a global perspective.
I would add to that, especially in communities that have little to no resources yet are doing some good work, because we could learn something from places that are doing really good work with very little to work with.
Other thoughts at the individual level?
I'm just thinking about, that's something that we haven't really talked about, or I haven't heard it, is how much more satisfying effective teamwork is. And it may be, I think a lot of people have said that people in practice don't really have the experience of effective teams, which makes faculty development sort of, it's a larger issue about somehow creating opportunities for people to have the experience that things can be different.
I think someone mentioned intrinsic it was with respect to self-assessment, but having self-assessment become an intrinsic motivator. And sounds like teamwork could be as well a challenge.
Yeah, I think that it's probably a huge proportion of people in practice have never really experienced that. We certainly do, whenever we innovate, that's going to be true. There must be best practices about how to do that.
In the queue. We're going to move on to our next slide. All right, save the easy one for last. So given the challenge we've articulated, the opportunities we've identified, can we start to outline a strategy to address this? And we're going to flesh this out in much more detail tomorrow. We just need kind of the global perspective on this today.
As far as concrete suggestions people could they give examples of particular actions that a stakeholder could take, or I was saying with respect to particular suggestions, specific suggestions that we could look for. If you have ideas of actions that a particular stakeholder or component of the process could take.
I think that, or to the extent that we can think of a big picture way to start to address this, and those component pieces are important to articulate. And my understanding is tomorrow we'll be fleshing those out in greater detail. But how would we take our first step to start to address this challenge?
And I think one question that we might start with is, we've laid out opportunities from a macro, meso, and a micro level. Where might we begin? Should we begin with the individual and work back to the policy? Or should we start with the policy and have it trickle down to the individual? And so I wonder if we can get sort of a consensus of what people think. Should we start at the policy level and work down? Or should we start with the individuals and try and look at individual faculty development and have that develop and have that trickle up to the policy level?
It's not an either or. I think we need to be working at all levels. And one of the levels we need to be working on is the graduate nursing education from CMS and graduate medical education from CMS, that this need to be part of what they would require in graduate nursing education and graduate medical education. So that is the finance that has been given to medical education for so many years and just being given now to nursing education. So I think that's where we need to start there and say that this should be part of the criteria of evaluation of how effective these programs are.
That to me sounds like a compelling argument for the importance of policy level action.
So that's working with CMS right now.
I'd just raise the issue for the group, and I made a comment the last time that I worry about whether our strategy is off base, in the sense that most of the workforce in health professions in the United States is employed. They're not learners, even going into residency. And we're not paying enough attention to the importance, and I think this is true in other countries as well, the importance of intervening and training the 95% of our workers who are actually in the workforce. The point being, we don't have 30 years to wait before all this, before the people we're educating go through. And all of our solutions are really focusing on the healthcare institutions and the learners who are in the pipeline.
Somebody mentioned the, may I
I'm
say?
sorry.
Oh, sorry.
I don't know.
Go ahead.
Somebody mentioned the magnet process. So that is addressing the workforce. So it's not, again, it's not an either or, which you and I are saying. So the magnet process, any of the organization that credential healthcare system can have that one of their criteria. You can imagine having it as part of the magnet process, what happened to the teams that quickly formed so that they would get a magnet status. So I think that's another group that we have to touch policy-wise again.
I want to echo the gentleman's point over there. I mean, the hard part about this is not the educational component. The hard part about this is the transfer. So if you teach or you focus on these aspects in education, but then people go into a work environment where none of this is valued and reinforced, or there's even opportunities to use it, it's not going to transfer. And so so there's two phases to it. One, how do you teach people these skills, and you can design assessments around it. But once they move to the workforce, whether or not they're going to maintain that on the job is really the key to all of this. So it's got to be, you're going to have to attack things on multiple fronts. I think there is attack going on multiple fronts. Problem is it's not organized. It's kind of individualized to each entity or even sub-entities within larger groupings of what they're doing. So I think the transfer equation is really the tricky part. And that's the part that involves so many factors with change and culture change and things like that that are a very big problem and a very big challenge to address.
I completely agree, and that's why I feel like we have to incentivize the current system to change. You have to start demanding that the current practitioners work interdependently with each other and expect that from the current providers. And then when, you have all these students that get out of school and they want to do that, but then they come into an environment where that they don't have time for that, that's not expected. So they learn that that's not expected of them. So, I feel like there's a lot of people with good intentions coming out of school, but then that's not the environment they're brought into. So I feel like you have to change the people who are actually teaching them in practice by making them have to change.
Let's not forget one of the most powerful constituents for us, and these are the consumers, the clients themselves. So the media would be really important to project what teams might do and have the consumers on our side in demanding that they be working with teams, because consumers sometimes come and want to work with one person and are confused by having a team. So having op-ed, those of you who can write op-eds, reach the media. I think looking at the kind of programs that come in TV, showing that. So I think that's really getting the consumers on our side to be demanding that would be really important.
Yeah, that was, thank you all. Please go ahead.
I think another way to put legs on the idea of data sharing would be to have an increased awareness of what each credentialing body requires so that the data that's being collected speaks to that. And so with one report, you can answer a lot of questions with the data you collect that is then meaningful not only at the academic level, but in the healthcare agency setting as well.
I'd like to thank all of you for this great discussion and for holding in with us till the end of the day. And since Patricia's in the room, I'm going to do my assignment. I have an announcement to read to you before you leave. As you know, there's going to be a reception following this. It's going to be in the atrium, not this room. The atrium is on the third floor. It starts at 5 p.m. At 5:30 p.m., there will be a poster session. There are steps and an elevator to get up to the atrium. And please keep in mind, tomorrow morning, we will start with the World Cafe. That begins at 8 a.m. sharp. If you are running late, the consequence may be that you're not allowed to get to your seat till later, so you may have to sit on the sidelines. And we'll see how many people are here tomorrow. I know a few people have left us already, so we may do some logistical shifting around with where people are located. Did I do okay?
Thank you all. And the reception is 2 flights up. The stairs are right there. There's a set of elevators. It'll begin at 5 o'clock. As we said, the poster session will begin at 5:30.
Thank you.
Thank you.